Greetings again. This is Vren Sommers, joined by my colleagues, Dr. Deborah Clegg and Dr. Greg Pressman. And this is part 2 of our podcast series on sodium and cardiovascular risk. We'll now transition to Dr. Greg Pressman, who will be talking about sodium as a driver of cardiovascular and cardiometabolic risk. Greg?
Okay, thank you, Vren. I'll present a second case. This adapted from an actual published case in the New England Journal of Medicine. This is a 57-year-old woman who presented for evaluation of hypertension. She had no history of cardiovascular disease, but she also noted a weight gain of 15 kilograms over the past 30 years, so 35, 40 pounds. On examination, her blood pressure was 155/95. Her weight was 189 pounds. Her height was 5 feet 5 inches. And very importantly, her waist circumference was 98 centimeters. The upper limit of normal in women is 88. She had triglycerides of 175 and HDL of 42. On laboratory testing, the LDL was 110, the glucose 94. On review of her diet and lifestyle, she was consuming a lot of processed foods and foods high in sugars and sodium, not too much in the way of fruits and vegetables, and her lifestyle was sedentary, so not so very different from many of our friends and neighbors. And I'll start with a question. Does this patient have metabolic syndrome?
Absolutely.
And for that, we need a definition, and for better or for worse, there are several, but here's one that I find useful. And this definition looks at 5 different factors with cutoffs. If the triglyceride level is 150 or more, the HDL less than 40 in men, less than 50 in women, a systolic 130 or greater, or diastolic 85 or greater, or the presence of hypertension medicines, fasting glucose 100 or greater, or medications for diabetes. And again, this waist circumference measure, which is different in men and women. And if we apply this to our patient, she certainly meets the blood pressure threshold, the waist circumference threshold. Her triglycerides exceed 150, or HDL is low for a woman. Her glucose is still in normal range, but with 4 out of 5, she does meet a definition of metabolic syndrome. And why is this important? Well, we know that metabolic syndrome adds risk for cardiovascular events and death, even after accounting for traditional cardiovascular risk factors. So each of those risk factors increases your chance of an adverse event or cardiovascular death. Putting them all together further increases risk. Let's talk more about hypertension in this particular case and others. We know that hypertension is associated with increased risk of stroke, MI, heart failure, renal failure, and cognitive impairment. In fact, hypertension is the single most important risk factor for all manner of cardiovascular disease and death worldwide. I've also mentioned earlier that in industrialized countries, the blood pressure increases dramatically with age. And this is probably related to the sodium intake of the population, because populations with low sodium intake do not experience this rise in blood pressure with aging. In terms of treatment, we always start with dietary and lifestyle intervention. For dietary treatment, there are 3 cornerstones: reducing the sodium intake, reducing body fat, and a healthful diet overall, such as the DASH diet, which has been discussed already. We know, as recently pointed out that sodium intake increases intravascular volume, cardiac output, peripheral vascular resistance, and all of these contribute to an increase in the blood pressure. Further, high salt intake increases the stiffness of conduit arteries, particularly the aorta and the carotids, and this causes a widening of the pulse pressure, whereby the systolic pressure goes higher and the diastolic lower, because you lose the buffering effect of the elastic aorta. And we know that that increase in pulse pressure is a very important predictor of cardiovascular events. Further, microvascular dysfunction can also be triggered in salt-sensitive individuals. By contrast, reducing the sodium intake can improve large vessel compliance even in older individuals, and in combination with a heart-healthy DASH diet or similar can result in substantial blood pressure lowering. So we see sodium reduction in a controlled diet and in combination with a DASH diet, leading to a marked reduction in blood pressure. And again, these are maneuvers that don't involve medications, and therefore avoid the cost of medications and the side effects of medications. These should be instituted in all patients who even have an elevated blood pressure, not necessarily meeting the threshold of clinical hypertension. So dietary change is likely to improve this patient's blood pressure. We should recommend a DASH diet or a Mediterranean diet, which is quite similar. We should recommend a sodium reduction to no more than 2,300 milligrams per day, but note the asterisk. 1,500 milligrams as a threshold is even better. And bear in mind that 1,000 milligrams of sodium is equal to 2,500 milligrams of sodium chloride. Her caloric intake should be reduced by 200 to 300 kilocalories per day, and certainly her physical activity should be increased. There's a good literature now that increasing activity prolongs life. So a question to consider: how much systolic blood pressure lowering can we reasonably expect with non-pharmacologic therapies? Is it 1 to 2 millimeters mercury, 3 to 5, or more than 5? Any thoughts from our other panelists?
Well, I would say that it would depend on the substrate that we're dealing with. For example, if somebody is taking in lots of salt and they're very salt sensitive, and they have a high blood pressure, then I would think that we'd be more likely to achieve a greater than 5 millimeter mercury reduction in blood pressure. So I think it really depends on who we're talking about. But overall, I would say if I had to just guess for the population as a whole, I would say 3 to 5.
Oh, I'm slightly more skeptical. I'm going to have to go 1 to 2. Diet and lifestyle intervention is really, really challenging. And so for a non-pharmacological therapy, unless she's losing a large amount of weight and actually increasing that activity, I'm afraid that it's going to be relatively modest. So I'm going to go for A.
So in fact, compliance with dietary changes is very difficult to achieve in most patients. However, if we look at the 2017 ACC-AHA blood pressure guidelines, here's a chart of non-pharmacologic interventions and the approximate impact on systolic blood pressure. And note that they break it down by normotensive patients and hypertensive patients. And across the board, you get more bang for the buck in the hypertensive patient. If you can get your patient to lose weight, it's expected that systolic blood pressure will reduce 1 millimeter of mercury for every 1 kilogram reduction in body weight. Overall, perhaps 5 millimeters. But look at this, a DASH diet, if a patient actually follows it, can result in an 11 millimeter reduction in systolic blood pressure. And that's more than some of our antihypertensive medications. If we reduce dietary sodium, we can sometimes get another 5 or 6 millimeters of mercury. Physical activity, again, a significant reduction. So the point is that these non-pharmacologic interventions with no medication costs or adverse medication effects associated with them can produce a lot of reduction in systolic blood pressure. Here is that DASH diet again that is recommended by the American Heart Association and similar to the Mediterranean diet recommended by the Europeans. We're emphasizing vegetables, fruits, whole grains, fish, poultry, and limiting fatty meats, full fat dairy, sugar sweetened beverages. And I am from Philadelphia, where we actually legislated this. And of course, we're limiting sodium ingestion to no more than 2,300 milligrams, but 1,500 milligrams is better. And with that, I'll thank you for your attention.
Thanks, Greg. That was very, very interesting. I have a question for you, though. In your presentation, you had earlier showed blood pressure and salt intake in different countries. And I was intrigued by the fact that Spain sat near the top as being one of the countries with a high salt intake and a higher blood pressure, if I remember correctly. And I always thought of Spain as being one of the Mediterranean diet populations. And I'm just trying to reconcile that high salt with the Mediterranean diet, or maybe that reflects the northern part of Spain that's far away from the Mediterranean.
It also could, yeah. It also could also represent the westernizing of Spain, right? Probably their original, more traditional diet would be much more healthy, but as it's become more westernized, perhaps there's much more consumption from fast food restaurants and the like, and maybe that's what's pushing them over into that higher category.
The European unionization of Spain. Okay.
Yes.
I think you may have been referring to the graph in the top right, which is looking at salt excretion, a measure of salt intake, plotted against stroke deaths. And here Spain did score high. This is a much older study, and I don't actually know, I don't have data on what salt intake was at that point, or if this is a national survey or perhaps an incomplete survey of just certain regions.
It's a question that I thought some of the audience may have, particularly since the Mediterranean diet seems so powerful, and Spain
I would note
is there.
that
but Deborah's probably right that behavior is changing.
Yeah, the Mediterranean diet has been popularized more recently, I think.
Mm-hmm. And I know that as I've gone to Europe over the past few decades, intermittently, there's many more McDonald's and fast food outlets and things like that than there ever were before.
Certainly.
No, and also they've added a lot of stabilizers to their bread, right? It used to be like in Germany, you'd buy a piece of bread and it was bad the next day. Now you actually can buy it and it lasts for many, many more days. It's because they're trying to increase the amount or the duration that the food can be on the shelf. So by adding shelf stabilizers, they're significantly increasing the amount of sodium per slice.
That is so interesting.